All right, let's jump right into it. In this explainer, we're taking a deep dive into the heart, but we're doing it in a super high-yield way that's perfect for nailing your exams. We're going to break down the key differences between right and left-sided heart failure so you can really understand what's happening with your patients.
So, get this. You've got two patients, and they both have a chart that says heart failure. But one is gasping for air, their lungs are totally waterlogged. The other patient, their lungs sound clear as a bell, but their legs are swollen up like balloons. How is that possible? How can both of these be heart failure? Well, that's the puzzle we're going to solve today.
And it all comes down to one absolutely critical concept. This is the thing you just can't forget. The heart isn't one pump. It's actually two completely different pumps working one after the other in a series. And understanding their unique jobs is the key to unlocking this whole mystery.
Okay, check out this slide. This diagram is everything. Over on the right, you've got the right ventricle, the RV. See how its wall is kind of thin? It's built for compliance. Its whole job is to handle a large volume of blood and gently push it into the low-resistance lungs. Think of it as a volume handler. Now look at the left ventricle, the LV. It is thick, it is muscular, it is an absolute powerhouse. Why? Because its job is to handle immense pressure, squeezing blood out into the high-resistance systemic circulation that feeds your entire body. It's a pressure generator. See? Two pumps, two totally different jobs.
So let's put this into practice. What happens when the pressure pump, the LV, starts to fail? Let's apply this to a real-world classic case of left-sided heart failure.
So, meet patient A. He's 65 years old, and he rolls in with that textbook story of crushing chest pain, and he feels like he's drowning, literally gasping for breath. These symptoms are basically screaming at you that there is a major problem with the high-pressure pump, the left ventricle. And yep, the findings totally back it up. What causes this? Often it's a myocardial infarction, a heart attack, or maybe years of untreated high blood pressure. The key number we look at here is the pulmonary capillary wedge pressure, or PCWP. Think of it as a sneak peek at the pressure in the left atrium. When that LV fails, the PCW skyrockets. And the result? All that pressure backs up straight into the lungs, causing pulmonary edema. Cardiac output plummets, and clinically, the lungs are wet.
So here it is, the bottom line. It's a simple but devastating chain reaction. The powerful left pump can't push blood forward, so all that pressure has to go somewhere, right? It backs up directly into the circuit that's right behind it, the lungs.
Okay, let's pivot. Now we're going to look at our second case, which presents a completely different clinical picture. And it's all because the other pump, the volume handler, is the one that's failing. Meet patient B. She's 70, has a long history of COPD, and her big complaints are these massively swollen legs and a really bloated belly full of fluid. Her lungs? She says they feel about the same as they always do. These symptoms of systemic swelling, they point directly to a failure of the volume handling pump, the right ventricle.
And this is where it gets really interesting. Look at the contrast. The causes are different. Things like a big pulmonary embolism or chronic lung disease like COPD, which make the lungs harder to pump into. The key pressure that goes up here is the central venous pressure, or CVP. And where does that pressure back up? Into the whole body. You see jugular venous distension, or JVD, in the neck, those swollen legs, even a backed up and large liver. But, and this is key, the PCWP is normal or low. The lungs are usually clear, at least at first.
And this just nails the takeaway for the right heart. The volume pump can't push blood forward into the lungs effectively. So the blood backs up into the circuit right behind it, which is the entire body's venous system. The fluid gets backed up systemically.
All right, time to shift gears. Let's do a quick rapid-fire review. This is pure, unadulterated exam gold, so let's really make sure these concepts are locked in.
This table just lays it all out perfectly. For the RV, the main stress is volume and the afterload it sees from the lungs. That's the pulmonary vascular resistance, or PVR. The number you're going to watch is the CVP. The clinical failure signal, JVD, and edema all over the body. Now for the LV, it's all about handling pressure and contractility. The key parameter is the PCWP. And the failure signal, you guessed it, pulmonary edema.
I love this slide. Think of it as a critical ICU cheat sheet. What makes each ventricle absolutely miserable? Well, the RV is super sensitive to pressure in the lungs. It hates a sudden spike in PVR, like you get from a PE or from low oxygen levels. And it hates being overstretched with too much IV fluid. The muscular LV,
It hates being starved of oxygen, that's ischemia, and it hates fighting against crazy high blood pressure, or what we call high systemic vascular resistance.
Okay, pop quiz time. You ready? First question. A patient with a massive pulmonary embolism suddenly becomes hypotensive. Which ventricle is failing? That's the right ventricle. That PE is like throwing a giant dam in the pulmonary artery, and the thin-walled RV just cannot generate the pressure to pump against it.
Question 2. You're examining a patient with an acute MI, and you hear crackles in their lungs. Which hemodynamic parameter is almost certainly going to be elevated? That would be the pulmonary capillary wedge pressure, the PCW. The heart attack damaged the LV, so pressure is backing up into the lungs, causing those crackles.
In question 3, why are the lungs typically clear in early isolated right heart failure? It's because the traffic jam is happening before the lungs. The RV can't push blood forward, so everything gets backed up into the body's veins. The problem is entirely upstream of the pulmonary circuit.
Okay, listen up. If you remember only one single thing from this entire explainer, please make it this sentence. Tattoo this on your brain. RV failure leads to systemic congestion. That means a high CVP and clear lungs. LV failure leads to pulmonary congestion. That means a high PCWP and wet lungs. That's the whole story in one line.
And I'll leave you with a final thought to chew on. Imagine a patient is accidentally given way too much IV fluid. Based on everything we just talked about, their design, their function, which pump do you think fails first? The right one or the left one? And more importantly, why? Think about which pump was built to handle volume and which one really wasn't. Thanks for tuning in.